Hello, in this video we're going to run through some of the common findings that we see on breast MRI. One important fact to remember is that we're imaging the same pathology, whether it's by mammography or it's by MRI. We just have the addition of the contrast in the MRI. So morphological features that would concern you on a mammogram, such as spiculation, will also concern you when you see them on an MRI. I'm just going to very briefly go through here the most common imaging features that we see with common pathology. I know there's a lot more detail I could go into, but this is really an overview. So invasive ductal carcinoma, the most common type of breast cancer. Generally speaking, it's going to have rim or inhomogeneous enhancement. However, it certainly can have homogeneous enhancement. It tends to have a plateau or washout type curve on the CAD, and that washout curve enhancement enhances to at least 60% above baseline and frequently more. However, about 5% of invasive ductal carcinomas have significantly less enhancement. And if the morphological features of the lesion concern you, then you shouldn't let the fact that it has a progressive enhancement pattern put you off. It's very common to see multifocal disease, and you may see interconnecting enhancing ducts, which is usually indicative of DCIS bridging between the different lesions. And you always want to look carefully to see if the nipple is involved or the lesion is very close to the nipple or the chest wall, because this is going to significantly affect management. So here is a typical invasive ductal carcinoma that's already been biopsied. These are just some post-biopsy changes that we're seeing here. Notice that the mass is spiculated. It also has these little tendrils of enhancement heading posterior and anterior, which is DCIS, which is proven on pathology. And then on the CAD, the enhancement pattern is a mixture between plateau and washout with also some progressive enhancement. And frequently mixed enhancement patterns are there, but you're going to look for the worst. We're going to talk more about nodal involvement in a minute, but you can see in this same patient, it's always very important to check laterally on the sagittal and all the way up on the axial images that she has some significantly abnormal nodes involved. Now, as I said, a small percentage of patients will have a very benign looking enhancement pattern. This is one. This was a small, low-grade invasive ductal carcinoma, and tumors such as tubular carcinomas not infrequently have this type of enhancement pattern. You can see that it's progressive enhancement, it's pretty homogeneous enhancement. However, notice here on the T1 no fat sat, and that's often the best image for looking for morphology, it's still a little spiculated mass. And if you saw that on a mammogram, you would say, I think that might be a little cancer, and same thing on an MRI. Now, what about invasive lobular carcinoma? This is a smaller percentage, about 10 to 15% of all breast cancers. And we know that the mammogram underestimates a significant percentage of the disease extent in invasive lobular carcinoma, or it may be completely occult mammographic. MRI is a really good way of seeing the extent of invasive lobular carcinomas, and when our patients have this, we virtually always recommend our MRs do a staging breast MR. About 50% can be either multifocal or bilateral, and the typical enhancement pattern is usually washout, but every now and then it can have relatively weak enhancement or progressive type enhancement characteristics. And similar to the mammogram, one of the things that we look for is architectural distortion. So this is a large invasive lobular carcinoma, which was virtually occult on this patient's mammogram. You can see here that there's a very irregular, poorly marginated mass. It has a mixture of progressive and plateau enhancement in this case, and this is a metastatic node that we can see posteriorly here as an intramammary node. Now, what about inflammatory breast cancer? Well, the key characteristic for inflammatory breast cancer on MR is that we see skin thickening and skin enhancement. There must be enhancement. And also enhancement of Cooper's ligaments. But note this is not an MR diagnosis and that you do require a skin biopsy to be able to show malignant cells within the skin itself to be able to prove this is an inflammatory breast cancer. But we can certainly suggest its presence on MRI. This is a patient with a very extensive inflammatory breast cancer. Note that they may not always be this extensive. You may have a much smaller tumor than this and still see a enhancement and involvement of the skin. So the key sign here, obviously she's got sort of multiple masses throughout her breast, is that the skin is thickened, but this skin is also enhancing here. And the CAD image just confirms this. DCIS can have a variety of different enhancement patterns, and MR is actually really pretty good at looking at DCIS, and the higher grade the DCIS is, the more likely we are to see it. But we do know that we can miss particularly low-grade DCIS on MR. So the enhancement patterns, as you might expect, again, think mammographically, can be ductal, they can be focal, they can be of more clumped ductal type or segmental pattern, and they may well have more benign kinetics of patterns such as progressive enhancement. So if you're seeing enhancement following along a duct, and particularly when it has this sort of clumped enhancement following along a duct, don't let that put you off from calling this DCIS just because it has a relatively benign enhancement. One of the things that MR is good at looking for is the extent of the non-calcified disease, so that disease that you may not be seeing on the mammogram. And its sensitivity is actually really pretty high, it's 92%. This particular study, they found that the MR was positive with a negative mammogram in almost half the patients. As I said, enhancement tends to be greater in the high grade rather than the low grade patients, which is not surprising. So in this patient here, you can see the enhancement is not, particularly intense, and in fact on the CAD it was progressive. However, when you look on the sagittal image, it is clearly following along in a linear or ductal type pattern. You can almost make this segmental, and this is sort of clumped in type enhancement pattern. I often find that the sagittal images are really helpful for showing the ductal involvement of DCIS rather than the axillary. And you can see here how on the sagittal image, it is much easier to see this segmental involvement of multiple ducts with DCIS. Again, not very intense type enhancement, but it's a little bit more difficult to see that when you look at the axial images. Now, what do we see after the patient has had surgery and or radiation treatment? We can only see macroscopic disease, residual malignancy, and if they say the patient has positive margins, negative MRI doesn't exclude the need for re-excision. Post-operatively, we're going to see inflammation. We may even see inflammation just after a stereotactic or core needle biopsy. And then there's going to be some form of scarring or post-procedural inflammatory change. By the time they are 6 months post-operative, if they haven't had XRT, we really should be seeing very little enhancement going on. When they've had radiation therapy, however, that is different, and they will have increased capillary permeability for about a year afterwards, and that can vary from very diffuse marked enhancement to patchy enhancement, and then gradually as that becomes more fibrotic, that enhancement's going to go. So you're going to have a period of time where the treated breast has more background enhancement than the untreated breast, and then typically later on that treated breast has less enhancement than the treated breast, particularly in the premenopausal patient who have a lot more hormonal stimulation going on in the untreated breast. So in this early period, 12 months after, you're really your ability to be able to diagnose recurrent disease or residual disease is going to be very limited in the presence of radiation therapy, and this should be considered more of a baseline study and the ability to look at the other breast in a high-risk patient. Well, fat necrosis can cause us all kinds of problems on mammography and breast ultrasound, and it can cause us all kinds of problems on MRI. Now, sometimes MRI is great and gives us a definitive diagnosis, but sometimes it doesn't. Unfortunately, fat necrosis can produce a nasty spiculated enhancement. It can have washout kinetics. But we do have the non-fat suppressed T1 images, if you are acquiring those, that can be very helpful in some of these cases. So this is a typical benign post-op seroma. The patient is just a few weeks after surgery, and you can see here that there is a little bit of enhancement in the rim, but it's all benign. It's pretty smooth. There's no big sort of nodules of washout type kinetics, which are going to. Now, this is a patient who has had a tram flap reconstruction, and we tend to see a lot of fat necrosis in these patients, and it can be a real diagnostic problem on occasions, and they can feel very ugly when you palpate them. And you can see here on the T1 gadolinium enhanced images and the subtraction images that, this kind of rim enhancement, it's spiculated, it looks nasty. But lo and behold, you look at the non-fat SAT images, and right in the middle of this, you can see fat. And so you can be very confident about the diagnosis in this kind of case. Unfortunately, if you don't see that central fat, these patients may end up needing to go to biopsy. What about fibrocystic disease? This is, again, one of our big sort of bugaboo areas for breast MRI. We see an awful lot of it. It's very variable. Particularly we see it in younger patients, but we can see it in postmenopausal patients quite extensively as well. And this may have variable enhancement characteristics. It tends to be more focal, but it can be quite diffuse. And it tends to have progressive enhancement kinetics, but sometimes you can get these little foci of more washout kinetics. And one of the things we're always looking for when patients have a lot of fibrocystic diseases, we're looking for the black sheep in the family. So we're looking to see, is there any one area that really looks different in terms of its morphology or its washout kinetics compared to any other area? And if the patient's got a lot of different little foci of enhancement scattered through one or both breasts, and they all look very similar, we're probably going to blow that off. Generally speaking, fibrocystic disease tends to be bilateral, so that can help us with that symmetry. Unfortunately, if the patient has had one breast irradiated and has much less background enhancement in that breast, then that isn't so helpful. You may well see larger cysts, which can help you, and generally speaking, high T2 signal corresponding to a small focus of enhancement is a sign that this is most likely going to be fibrocystic disease. So this is a patient who has a lot of macroscopic cysts. You can see here they have a few little odd foci that are not clearly cystic scattered around, but you'd be pretty confident in this patient just calling this fibrocystic disease. They tend to be high on T2. Sometimes if you have a more hemorrhagic type cyst or a cyst that has high proteinaceous content, it will be high on the T1 image, but it's going to be high on the T1 image both before and after gadolinium, and will subtract out. This is a much tougher case to interpret because this patient doesn't have macroscopic cysts. They have this very high background parenchymal enhancement. Obviously, finding a small cancer in this patient is going to be very limited, but you can see how symmetrical these multiple regional foci of non-mass enhancement are in both breasts. Now, could she have diffuse DCIS in the lateral aspects of both breasts? Yeah, it's possible, and you're going to have to make a judgment call on that. Obviously, it's nice if this was not the patient's first breast MRI and you had another one to compare it to, but we're not always as fortunate as that. So again, you have to look very closely through these patients and really try and look and see, are there any of these areas which are enhancing differently than the others? Are there any black sheep there? Background physiological enhancement tends to be worse in younger women. and in younger women it's cyclical and it's maximal premenstrual, which is why we try and scan them in days 7 to 14, because you can really get yourself into a world of hurt trying to scan a patient immediately premenstrual and they've got a lot of background parenchymal enhancement, and your chances of missing a cancer are much greater. And occasionally in these patients we have to repeat their scan, usually at no cost. So this is a patient who has very high background parenchymal enhancement. Don't forget that we judge background parenchymal enhancement compared to the amount of fibroglandular tissue. We're not looking at the enhancement of fatty tissue. So this patient has heterogeneously dense breasts, but has severe background parenchymal enhancement. And as I said, even though this particular patient was imaged an optimal time of her cycle, she was only 35 years old, and MRI is going to be an undoubtedly lower sensitivity in her. I kind of like this rule, the 5 millimeter rule. If it's bigger than 5 millimeters, it's got to prove it's benign in some way, where if it's smaller than 5 millimeters, it's got to kind of prove it's malignant. So you're going to use the shape, you're going to use the margins, the kinetics, the enhancement, whether there's a mammographic ultrasound correlate, whether there's stability, and so on. Unfortunately, a lot of little foci of fibrocystic type change can have washout kinetics, so sometimes that's not very helpful to us. However, if all of both of the rest of the breasts have benign type kinetics and you have this one focus with washout kinetics, you're going to be more concerned about it. This always sticks in my mind because when my kids were at junior high school, there was a 5-inch rule about skirt length. They had to be less than 5 inches above the knee or they used to be sent home. So if your lesion is greater than 5 millimeters, you've got to have a good reason not to. So here are two separate lesions, two different patients. The one on the left was a cancer and the one on the right was just fibrocystic change. So what's the difference between them? They both actually had plateau type kinetics. This one has spiculated margins where this one is smaller and it's round and smooth, and this one did actually get biopsied but was just benign. Let's move on to talking about lymph nodes. So lymph nodes always have intense enhancement and washout type kinetics. Lymph nodes look like lymph nodes as they do in any other modality. We're typically a reniform shape when they're normal, but they do tend to have very high signal on T2, so they're sort of light bulb bright, and this can be a clue that something is a lymph node, a normal lymph node, not a little mass. If they are big enough, you can look at the T1 prefat sat and see if they have a fatty hilar. As I said before, it's very important that we look very closely at the axilla, and we also need to look at the intramammary node area to see whether there's any metastatic disease. So as metastatic disease occurs, it can have different appearances. So they may lose a fatty hilar and they just become little round shaped masses or focal nodules. The size is less helpful because you can have 3 centimeter completely benign appearing lymph nodes with fatty replaced hilar in the axilla. Our specificity tends to be greater than our sensitivity because we're not able to detect microscopic disease, and frequently it's helpful to go to ultrasound and then biopsy for confirmation. So here's some different patterns that you might see with metastatic nodes. The normal node here has thin cortex. The cortex should be less than 3 millimeters with fat in the middle. This one, there is entire replacement of a node, which has become much more round. This node has extranodal extension, and that's a very concerning sign that's very specific for metastatic disease. This one, there's diffuse cortical thickening, and this can happen both in inflammatory conditions with hyperplastic nodes as well as metastatic disease. And then little focal nodules either extending into the hilum or externally on the cortex are concerning. And the resolution of MR in the axilla is sometimes not good enough for us to really get good resolution of these nodules, and so we refer the patients to ultrasound for further evaluation, and some of them just turn out to be lobulations. So typical normal lymph node, we can see here on the T1 non-fat sat that there's fat in the hilum. It looks like a lymph node. It's high on T2 and it enhances brightly, and this will have washout kinetics. It's another normal lymph node. Although it's quite big, we can see that it has thin, albeit lobulated cortex. It's still got fat in the hilum. It has a feeding vessel into it, another clue. Here are two different patients with nodal metastasis. This one we saw earlier with these big, bulky nodes with complete replacement of the fatty hilar. But these nodes, if you look, are irregularly marginated. So this is extranodal extension of disease, and that is going to be managed very differently by the breast care team than if there was no extranodal extension. One of the things that concerns us is if we have thickening of part of the node, but not another part of the cortex. And you can see here the MR and the ultrasound correlate very nicely in this patient. So this was probably about 6 millimeters thick here. This is normal cortex. Obviously, when you biopsy this patient, you want to be biopsying through that thickened area, not the thin area. This is a patient who has about a 2 centimeter invasive ductal carcinoma here. And despite a relatively small tumor, this is an abnormal round lymph node, which we biopsied and was metastatic. And one final case here, this patient has on the MRI some they're not terribly abnormal in terms of size, but you can see that there is sort of lobular thickening, and when we look by ultrasound, we can see nodules extend into the hilar as well as nodules extend outside of the cortex. And again, this is a metastasis. Cysts, which we see commonly, as I mentioned before, they're going to be bright on T2, same as cysts anywhere else in the body. They should have smooth borders. And if proteinaceous or hemorrhagic, they may be bright on T1. And it's not uncommon to have an inflammatory cyst where they have smooth rim enhancement around it. And you have to look very closely to make sure you correlate it with the T2 as well as the T1 pre-contrast images to make sure that you are seeing an inflammatory cyst, you're not seeing the little rim enhancing mass. So typical cyst, just a little bit of rim enhancement on this, nothing much. High T2 signal, so this is a pretty simple cyst, not particularly proteinaceous or hemorrhagic. Fibroadenomas are common, and we commonly see them on MRI, and they should look like fibroadenomas on any other imaging modality. They tend to be oval or very gently lobulated with smooth margins. They tend to have homogeneous, progressive type enhancement, and it's nice if they do, but they don't always have this if they have dark internal septa, which is almost pathognomonic for a Some fibroadenomas are not quite as helpful as others, and they may have atypical appearances. They may be more lobulated. They may have plateau enhancement, and it's not that uncommon for them to be bright on T2. Usually these are more myxoid type fibroadenomas, and that's a sign, that's a positive sign that this is a fibroadenoma if we see it along with the other features of being smooth and well marginated. Obviously, if you see something that is spiculated, just because it's bright on T2, you don't necessarily want to blow it off. So these are 3 different little fibroadenomas. Sorry, they went a bit fuzzy on me when I tried to blow them up, but you can see here that they're all oval. There's benign homogeneous kinetics on this one, and these here are these dark internal septa, which we can see in some fibroadenomas, which are pathognomonic for that finding. This one didn't read the rule book. You can see here that it's a much more lobulated type mass, that there is mixed plateau and progressive kinetics with it. And would I biopsy this one? Yes, absolutely, unless I knew that the patient had a fibroadenoma or that it had a stable mass when you correlate it with mammography for many years. So you can stop here if you want. That was just a brief run through of some of the typical findings that we see on breast MRI, but I'm going to continue on and look at some cases, and you're welcome to come through these with me. So this is a baseline screening patient on a high-risk patient. I forget what she was high risk for, but you can see here there is a significant difference in that sort of background parenchyma enhancement between the right breast and the left, and she had not had radiation treatment to her right breast. There are a number of features which concern us when we look at this. For one thing, that this enhancement is clumped. It forms a linear or ductal type pattern in many places. It's really more than a segment. It's probably regional type enhancement. But the kinetics are not very exciting. A lot of it is actually subthreshold. But just the distribution of this enhancement should concern us. And this ended up being 10 centimeters of DCIS at surgery. So this is a patient who has a known right breast cancer, and on her left breast MRI, you'll see she had this little enhancing mass. It has washout kinetics. It's high on T2, so we're thinking it's a lymph node, but is it a normal lymph node? It certainly seems to have a little bit of asymmetrical cortical thickening. So what we did next is we took a look at her mammogram. And you can see on her mammogram, she has a corresponding lymph node that had been stable for at least 3 years, so we totally ignored that. And this just shows the importance when you see an abnormality of looking back at the mammogram before you start calling them back for additional imaging. So this is the sort of breast MR that if you open up, you hope that one of your colleagues will read and you're tempted to close it again, because you can see that there is this very intense background enhancement in both breasts. But note it's very symmetrical. It all has benign progressive type kinetics here, and there's no one kind of spot that really stands out to you from the rest. But obviously our sensitivity in this case is extremely limited. And when we look at the T2 signal in her, she has high T2 signal with macroscopic cysts throughout both breasts, and so we just call this benign fibrocystic change. Now, should this patient continue to have breast MR screening? Well, one could debate that our sensitivity is low, but it doesn't mean now we've got a baseline that we'll not be able to pick up a cancer at some point. This is another high-risk screener, and this is one you open up and go, yay! I'll interpret this one. It's going to take me no time whatsoever because there's nothing on subtraction. However, if you look closely here, there's no contrast. So this is pre-GAD, looking at the heart. This is post-GAD, and this patient has had a gadolinium infiltration. And so this is a non-diagnostic study, and the patient needs to come back for another one. She does have a large macroscopic cyst in the right breast, which doesn't enhance because it wouldn't enhance anyway. This is a lady who is status post lumpectomy and radiation treatment for an invasive ductal carcinoma. And you might first of all start to get a little concerned and say, well, are these spiculated type margins here? But this is really very even, very symmetrical throughout. It had progressive type kinetics, as you can see here. And this is really just benign post-surgical change. It's high T2, so it's still a seroma. It's not fat necrosis because we don't see fat in the non-fat SAT images. Now, this lady had presented with a palpable mass here, which had been biopsied and been shown to be invasive ductal carcinoma. I think it was about a 1.5 centimeter tumor. But you can see here on the MR, there's a lot more stuff going on. So she has this segmental type enhancement heading towards the nipple. These are blood vessels on the external here. She has another little nodule of enhancement here, again, all following along that same ductal tract. And this turned out to be extensive DCIS associated with an invasive ductal carcinoma. I often find the MIP images, either the CAD ones or the non-CAD subtraction ones, are very helpful for showing extent of disease in these patients, and they're always the first images I look at just to get a sort of global feel of the breast, but they're very helpful sort of for being able to get one measurement of the extent of the disease rather than trying to get it from multiple slices. This lady had about 3 centimeters of fine pleomorphic microcalcifications on her mammogram, which were biopsied and shown to be DCIS. But again, you can see that when you look at her MR, she's got a lot more than 3 centimeters going on, and she has a sort of totally classical segmental type enhancement pattern showing here, and this was all DCIS. There were no invasive components at surgery. You want to check closely for artifacts, especially artifacts that can cause problems with fat suppression. This can be due to patient movement. It can be due to the curvature of their breast or how their breast is positioned in the coil, or it can be due to things like this, which is from the patient's infusion port. So you can see here what the effect of the infusion port is. It is altered the fat suppression surrounding it, so this looks like it's an enhancing lesion, but if you look closely, it's going to look the same on both the pre and post gadolinium image. When you look at the non-fat SAT, where we don't see this effect, we're not seeing that there. And when we look at the subtraction image, here's our MIP subtraction, and there's absolutely nothing in that area to suggest abnormal enhancement. This lady was undergoing a staging MRI for a right-sided breast cancer, and we saw this left-sided breast mass. We could not see it on mammography. Now, when you look at it closely, you can see it's lobulated. It's got pretty low-grade progressive type enhancement, but I think you can talk yourself into there being some dark septae within that mass. Now, she had very high T2 kinetics on this, but this is not a cyst because it's enhancing, so it's a solid mass. And we did take it to ultrasound. And she had a very benign-looking lobulated mass that we were pretty confident was a fibroadenoma, but she elected to have this biopsied, which was confirmed to be a myxoid fibroadenoma at core needle biopsy. So this is what can happen if you scan a patient the wrong time. So she was scanned immediately before her next expected menses. The tech didn't take a good history, and you can see this really high background parenchyma enhancement. And again, our ability to diagnose cancer in this situation is very limited. So she had to come back for a repeat scan, which was negative. This woman presented with a palpable mass, and we see she has this sort of nasty looking conglomeration of rim enhancing masses in her right breast. But what you notice here is that her skin is thickened and her skin is enhancing. So this was a biopsy-proven inflammatory breast cancer. We did perform a core needle biopsy of the palpable mass before the MRI was performed, however, which confirmed the diagnosis of an invasive ductal carcinoma. This 50-year-old woman was BRCA1 positive and had a totally normal mammogram, but you see here this segmental and linear or ductal type enhancement. Again, there's some sort of clump type features in it, very suspicious of DCIS, which was confirmed at biopsy. She went on and had bilateral mastectomies, with the contralateral one being prophylactic. Now this is an older lady, just withholding her history for a minute, and we see here in her right breast, what really draws our eyes is linear enhancement, clump linear enhancement sitting right here, has a sort of branching ductal type pattern. And then if we zoom out so we can see her other breast, I think the MIP images again are really helpful here, so the asymmetry in the enhancement between the two is the nipple enhancement. So nipple enhancement can be totally normal, but it should be symmetrical. And if you're seeing asymmetrical nipple enhancement on an MR, you need to be concerned about it. And this was a lady who did have Paget disease of the breast, which was associated with DCIS. Now, this lady had a biopsy-proven invasive ductal carcinoma in her left breast, but she also had swelling of her left breast. So we were concerned about her having an inflammatory component. But notice here that the T2 signal in this thickened skin, she definitely has thickened skin, is very high, and there's no actual enhancement when you look at the subtraction image. Now, when you look up into her axilla, this lady has very extensive nodal involvement, and this was actually lymphedema in her left breast due to metastatic involvement of these nodes. This is another high-risk screening patient, and when you look at her gadolinium enhanced study, you can certainly see a lot of ductal type of high signal here, but when you look at the pre-GAD image, you're seeing a very similar pattern. And on the subtraction image, there really is no enhancement, but it is not particularly high on T2 image. It's a little bit high. And this is typical ductal ectasia. The ductal ectasia signal on T1 and T2 is going to vary depending on whether it is proteinaceous fluid or not. So very less proteinaceous fluid will tend to be dark on the T1 and bright on the T2, and vice versa for proteinaceous fluid. Here's a nice straightforward study. This is one that you hope is in your pile that you open up. So she has about a 1.5 centimeter spiculated mass that intensely enhances here in the lateral aspect of her left breast. Now, when we look at the CAD image, she has very benign, mostly progressive type enhancement pattern, but you don't want to start calling this a fibroadenoma just because it has benign type kinetics. It's a spiculated mass. Fibroadenomas are not spiculated mass by mammography, and they're not by MRI. She does not have high T2 signal in it, another clue that we should be concerned about this. And this was a low-grade invasive ductal carcinoma. And one final case here, this is an older lady who presented with a diffuse thickening of her breast, no focal palpable mass, and you can see on the mammogram here, there's some pretty subtle asymmetry between the two sides, maybe a little bit of skin thickening, maybe a little bit of nipple withdrawal here. And on her MRI, she had this very ill-defined spiculated, it's really non-mass type enhancement rather than a mass in the lateral aspect of her left breast, and this had mixed progressive and plateau type enhancement kinetics, and this was an invasive lobular carcinoma. All right, so I'm done here. I hope that's just a very brief overview of some of the common findings that you read on breast MRI, and will just help you a little bit in your breast MR interpretation.